Good morning, everybody. Welcome to the MAC, the Mental Health and Addiction podcast. My name is Andy Bernstein, and joining me as always is the great Kristen Perry Long, who is now back in the saddle, back in Massachusetts, living the dream, doing her thing. Kris, who are you?
My name is Kris Perry Long. I am the mother of children in recovery. I am also a family ed facilitator for Aware Recovery Care, which is a 52-week in-home addiction treatment program here in Massachusetts. And
You are the
life.
You are the most dedicated individual out there when it comes to addiction and recovery. So, Kris, why did we start the MAP? Just tell people.
So we started the MAP a while ago
I know, can you
to help raise awareness, to talk about things that people maybe don't want to talk about because of shame and stigma. We want to raise awareness. We want to address issues that are out there that maybe people, like I said, aren't aware of, and bring attention to like the positive, not always the negative.
There you go. Okay. Thank you for that. Our third member of the team is the great Willie Drinkwater, who was on assignment today. So we're not going to have his expertise and loving charm and, that good stuff. And as for me, I'm Andy Bernstein. I've been working in media for over 25 years, and I believe in the power of it to help bring light and impact change for important issues such as this mental health and addiction epidemic. So before we get into today's topic, which is Kris's take, which we'll explain. Quick piece of news. The Executive Office of Human Services for the state of Massachusetts, along with the Department of Public Health, has announced a grant of $800,000 for two new residential treatment facilities for teenagers struggling with mental health and substance use disorders. The grant recipients are the Center for Human Development in Chicopee and the Lowell House in Reading, Mass. And both of these organizations aim to provide critical treatment services for young people in Eastern and Western Mass with a combined capacity of 39 treatment beds. And the Center for Human Development has 15 beds for teenagers ages 13 to 17. And Lowell House will have a gender-inclusive population of teenagers 13 to 17, doubling the number of youth treatment beds in the state. And these are awards that are part of our ongoing investment in life-saving addiction treatment programs, especially for young people struggling with mental health concerns and substance use. And that was from Marianne Scudders, who is the Health and Human Services Secretary. So here's my take, right? And Kris, I'm going to play devil's advocate, okay? And you can challenge me on this. So I think these programs are great, but as someone who is not a parent of someone in recovery and not a person whose kid is struggling with substance abuse or addiction or mental health issues, how do we take programs like this and help kids use these tools, for life? So it's not a continuous like, oh, okay. Like I know someone, he was a kid, he was using marijuana, he was sent off to rehab, he came back and now he drinks. And it's become more acceptable because he was a young guy. And he's like, I don't want that label of being an addict at 17, 18 years old. So my question to you is, don't you agree, or do you agree that there needs to be skills being taught or some virtues being taught, like accountability and character, and maybe even having some metrics to make sure that young people are actually getting on the right track rather than just continuing, okay, now they're 13 to 17 in a treatment center, so now they're 24 and they're in a treatment center, So I wanted to get your thoughts on that.
Yeah. So first of all, in the state of Massachusetts, we only have, as far as I know, um, one active program for adolescents. And I don't know how many beds is it. It's MYR, is what it's called. And I can't tell you how many calls I get for 13, 15, 16-year olds. It's a tough age. They're going through a lot of stuff. Um, and in schools, I think in schools, we really need to bring back the education and about drugs and alcohol. It's only really touched on. There's not a lot of supportive services in enough schools for kids to be able to go to. They have guidance counselors, and
Right.
I have clients like that are guidance counselors, and their thoughts is like, we can only do so much, right? We can only do what we can do. And being mandated reporters, if a kid says something about what's going on at home, mandated reporting means you have to report, and then you get DCYF involved, and then it's like a complete, shit show, to be frank, because now you're bringing, children's services in. Sometimes the kids get removed, and what happens, right? What happens to that kid? Because they were open and honest with what was going on at home, now they've been removed from the family. Who knows what mom and dad or whoever their caregiver's reaction is, and it just cycles. So then they turn to drugs and alcohol as a coping skill for being open and honest. And I think that, like, we've just lost our communication skills. We've lost the ability to be open and honest without punishment. And so, yeah, they need some life skills. They need some coping skills. Um, I mean, people use drugs and alcohol to numb away whatever it is that in life that is, eating away at them. More times than not. When you use something like heroin, it's a little bit different. You use heroin and you're like almost immediately addicted to it. But then your excuse is to keep using, you don't want to be sick. So, heroin users, they don't use because they want to use. They use because they don't want to be sick and they don't have a solution. So,
Right.
it's just a big cycle. We just cycle. So I think it's really important. We need something for kids. There's not enough
I
programs in Massachusetts, wait a minute, that accept Mass Health. You have, mom and dad's insurance, that's like private insurance. We can send you out of state, not that far, Newport Academy, Turnbridge, great programs. They do life skills, they do education, they do counseling, they do nutrition, they do all of that stuff in their programs. Here in Massachusetts with Mass Health, not so much. So all you do is you remove the substance from the child and you put them back into the home, and we know what happens. It just continues. You can't remove somebody from home and return them to a sick home still. And that's part of the reason why I love Aware so much, is because we really work with our families. Not only, we get educate them, and then we bring in therapists into the family to make the family whole again
so
while addressing the problem.
but I was reading and it was like grants, when you give out a grant, a lot of times the grants are supposed to have some outcomes to it.
Mhm.
Like, we gave this money and we hope to reduce whatever, but it doesn't sound like there's any grants. I mean, there's any metrics. And one of my issues with this whole thing is that, okay, we know it's a problem. We know drug addiction is a problem. We know there's an opioid problem. We know there's overdoses. We know all this, but how what are the outcomes? Like, what can we do to start having a measured understanding of this? Like, really, like putting some science to it, or some to numbers, to say, in this course of the year, and I don't know, then maybe they do this, but and we had 88,000 overdoses. Well, how do we say, okay, this year we want to reduce that by 10,000 or 15,000? Like, what is the plan to do that? And is there such a thing? And or should there be such a thing?
Well, you really can't measure recovery, um, because I don't know. I was told a long time ago that if you look at a treatment center and you ask them what their recovery rate is, and they say it's like whatever, there's really no way that you can,
It's not
yeah, there's still,
quantifiable.
right. It's not. So I think the bigger question is, what we need to follow these kids. So say this kid comes in at 13, right?
Right.
13 to give up a substance, whether it's marijuana or alcohol, and go through your teenage years in today's day and age, maybe in an unhealthy home or a healthy home, how what worked to keep that 13-year-old to 25 sober? What worked? What was it? Well, studies do show that, accountability, education, support, like the right support. Okay, so this is great. We've got programs for 13 and 17 to 17-year-olds, right? But where do they go after that 30-day program, that 60-day program? Where do they go for that support? They have a therapist. That's great. A therapist once a week, once every other week, once a month, whatever. They need somebody in long-term recovery, an alcoholic in long-term recovery. They're going to tell you they go to AA meetings, and that's what kept them sober, right? They go to AA meetings weekly, and they've got 25, 30 years. They might go 2 times a week. They might go 3 times a week. They might have a sponsor. What are we doing for those kids after?
That's what
So
I'm
I mean,
saying. Right.
yeah.
What is the,
What's
you
the
know,
bigger picture?
yeah, like, because I don't, it's like throwing, yeah, it's nice they're giving a grant, but, it's like, it's kind of like teach a man to fish kind of thing. It's like, and he can eat for life rather than just giving him a fish. And
Right.
for me, this has started to change for me since I've been doing these shows. I started to be like, okay, how do we, okay, we know the problem is there. How are we going to start fixing it? Right.
Right.
Like, how do we start to really tackle this stuff? And what are we
So,
doing?
so like aware, right?
Yeah.
Not to preach on it, but it's a 52-week program. For
Right.
52 weeks, we are putting touches on our clients and our families, and we are supporting them. And if you can put 52 weeks, and it doesn't matter if you have reoccurrences anywhere along that, we're not a punitive company, right? We're not a punitive program. What we do is we support our clients, whether you come in and you're in active addiction or drinking, by the time you leave, we have people that come in and at like 40 weeks, they're still drinking. And then at 42 weeks, the light goes off. And in
Right.
10 weeks later, they graduate, right? What have we done? And I have to say, I've been with them since August and have watched how it worked. And it's the constant support. It's the constant guidance. You look at something like Recovery High School, right? So
Yeah.
they come in all different ages, and that would be a great guest to have is somebody from Recovery High
It's
School.
John,
It's,
what's his
it's a woman. It's a woman. I don't remember
there's a
what her name
guy,
is.
John, yeah, I can't, Willie, I think Willie knows her. I'm sure Willie knows one of his
But what they do
16,000
is
people in
they
LinkedIn.
have Recovery High School is beautiful because what they do is they get these kids at whatever grade, right? And they continuously have that touch on those kids for 2 or 3 years. And, through good times and through bad times, but they're just there. There's that support. And did you watch that MTV special that they did on Recovery High School, North Shore Recovery High School?
No.
So, it was amazing. It was so they followed every show. They followed a couple of kids, and a couple of kids died. Reality, sad.
Right.
But they followed those kids, and what I found most interesting is that those kids, there was no judgment in that school. There was only support and understanding. And, so if a kid relapsed, the kids were going to the principal before they were going to their families. And,
Well,
and that says a lot.
Well, that's the other thing I was going to say is it's like, okay, you come out of rehab and let's say addiction's going in the home, right? That the parents are using. Um, how's that impacted a kid? It's like, okay, I've been in this rehab, I go home, and then mom and dad are drinking up, drinking like fishes.
Yeah.
How does that, promote long-term sobriety? So it's there's no perfect argument for this, right? As you know, but I'm just thinking like, God, it's such a big problem, and now it's getting worse again
Yeah.
because it was getting better, right? And now it's getting
Oh
worse because
yeah. The epidemic is really, I mean, the pandemic is really, it's scary what the pandemic has done. It's
oh,
been a
without
setback.
without question. Now, okay, so you there?
Yeah.
Okay, good. I don't know what kind of operation you're running there at home, but okay, so then you had a topic you wanted to discuss today,
Yeah.
about buprenorphine, which
Buprenorphine, right, which is Suboxone.
okay, and so there was an article just came out by um,
Health
talking.
City.
Okay, and it was talking about how they have changed the prescribing guidelines, and they're saying it won't solve the opioid crisis. And this will um, from Miriam Komarami from the Boston Medical Center Graken Center, cautions that the new rules don't go far enough in addressing opioid overdose deaths. Now, didn't they have another person running that department? Was it Michael Botticelli was running?
Yeah, I thought he was. This is the Graken Center where
Right.
somebody gave like
John
stupid
Graken gave like $30 million.
$1 million or something. Yeah, I don't know. But what's really, really scary is, so okay, let's back it up a little bit, right? And go to the history of the whole disease, right? So Purdue Pharma, the Sackler family started producing opiates. And the marketing, we know what happened. The marketing was presented in such a way that these are non-addictive, taken the right way, blah, 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 right? And then boom, we had this explosion. Well, the Sackler family also produced Suboxone. They were Purdue Pharma was we're going to make you an opiate addict, but we're going to give you the solution. So it's like all about money, right? It's ridiculous. Oh yeah.
Oxycodone.
And what I've learned over years is like, so when a manufacturer produces or makes a pill, they have the rights. You can't make a synthetic pill for a long time. They have like something, I don't even know what the time frame is.
I think it's
So
10 years.
they had the Percocet, right? They started with the perks and they expanded on the perks, and they had like exclusive rights to those for a very long time. And then when that exclusion and the synthetics and the alternative or whatever they're called came up, that's when they produced the Oxy. And then they had the exclusive on the Oxy. So even though they lost the exclusive on the Percocet, they now had the Oxy, which was more powerful, more addictive. Again, marketing. Now we have this opiate problem, right? What are we going to do for the opiate problem? Well, we're going to produce Suboxone.
Well, let me interject too, because I read a book called Drug Dealer MD, and she talks about how what they were doing with the Oxycontin and oxycodone was they got a letter written by a Boston Medical Center professor back in 1980, or was a Boston Medical Center um, research a clinician, a researcher or whatever, and wrote a white paper that said that these drugs were not addictive. And so
Right.
they gave it to the marketing department at Purdue Pharma to go out, and they were giving away trips, and they were giving away all kinds of
Incentives.
incentives to prescribe it, saying this is not addictive. And
Right.
that's why they've been hit so hard, because they knew it was addictive and they didn't care, and they kept
Well,
going.
you know what else is really funky is that, so they just did a show. It was on like I don't know what it was on. It was on TV.
Right.
And it was I can't remember the title of it. It was just a couple weeks ago. But what they said, they went back from the history. 1954 is when the very first Sackler person, something 1950 something, was when the very first Sackler bought the very first pharmacy and started producing. And they did in a roundabout way in the 80s, I believe. They had an FDA person in their back pocket.
Yeah.
And then that FDA guy left and started working for Purdue Pharma. So like there's so much backdoor stuff that hasn't yet been exposed. So with the Purdue, so I'm working also on the Purdue Pharma lawsuit with a lawyer's office. And
What are you, Aaron Brockovich?
no, I'm just
Okay.
I'm doing whatever. So what I've learned is that like, so a settlement has been accepted by the law firms for the Purdue Pharma lawsuit. Right. So we have a clientele of like just under 2,000 on this lawsuit with this particular law firm. And what we have to do now is in order to receive some of that settlement, be a part of that settlement, we have to prove that they got a Purdue Pharma drug.
Okay.
Right. So what we have to do is we take their social security numbers, and we're working with an outside program, and they go into the database and it pulls up all the prescriptions you've ever been prescribed in your life. And then you have to go and you have to see where they were produced, who made them. But it's crazy because the stories that I've heard from these people, because you get to know them, I've had to take statements and everything else. Like it's surgeries, it's dental,
It's construction workers.
It's construction workers. It's like it's everything. Like it's insane. Like we have different categories. We have the people that have lost their loved ones because of it. Basic story. He went in for shoulder surgery, got addicted. Within a month and a half, was dead of an overdose because he had shoulder surgery, wasn't educated on the whole pill thing, and boom, gone.
Yeah. Oh, so let's talk about buprenorphine because of understanding that people think opioid and they're thinking maybe it's heroin, but it's not just heroin.
Synthetic heroin.
Right. So just because you're taking it in pill form in Oxycontin or oxycodone, it's still has the same effects of heroin.
So what they did was they used to produce pills. You used to take Suboxone, and it was, you put it under your tongue and it was a quick dissolve. And then people were abusing it. So, gee, why? It gives you the same feeling. People were overdosing from it. Like
from Suboxone. Okay. What wasn't that like methadone? It's like methadone?
No, it's synthetic heroin.
It's synthetic heroin. Okay, I didn't know that. Heroin. Okay. All right.
So it's an opioid. So what they did is they made it into a film, right? And again, you put the film and it dissolves. But you're only supposed to have, you're only supposed to take, I don't know the exact dosage. I think 16 is like the maximum you take a day. But what they're doing is they're just giving you, it's a film and it comes in a package, an aluminum package, and they give you a week's worth, or they give you 2 weeks worth, or depending upon who you go to. They're not supposed to, but depending upon who your provider is, it's so loosey-goosey that it's just another whole problem. And if anybody's listening and they've been on Suboxone and they want to chime in, please feel free to chime in. People will tell you that the withdrawal from Suboxone is far worse than the withdrawal from heroin.
Wow.
And so what happens is you go and you get prescribed Suboxone, and you're taking it like you want to take it, but you go to an AA meeting and you admit that you're on Suboxone, and then you're shunned because you're not clean. So I can't tell you how many kids are like, I'm on Suboxone, but I haven't told anybody because I don't want to, so they go off of it. They just like, I'm going to be getting my 12.
But what's the difference whether you're taking a synthetic version or you're taking a regular version?
Because what it's supposed to do, right? What it's supposed to do is we have all these receptors in our brain. The Suboxone goes to those receptors, and it's supposed to like curb those cravings. If taken the right way, it won't get you high. It just takes away those cravings. That's the intended use of Suboxone, to help you with the cravings. Unfortunately, what they're doing now is it's going to be a free-for-all because they're not educating the doctors. They're not making it required. They're not educating the doctors as to the dangers of Suboxone.
That's what the
article is saying.
Is there a plus though to it, Mike? Can we put up the article? I always wanted to say that, but there's no positives to this, having the restrictions.
It's so it says right here, so it says, like, if you talk about the article, right, it says more than 87,000 deaths were up at least 5% in 2020 from the epidemic. Yeah, it's a very, very scary thought. Now medical providers are able to prescribe the medication without needing to take the course training that was previously required. So that means your GPs can all of a sudden provide Suboxone without any type of education.
So we're back to why they gave oxycodone or Oxycontin with reckless abandon. Now it's like, okay, well, we're not doing that anymore, but we're going to give you Suboxone
Right. So I could just go to my doctor and be like, hey, I have a heroin problem, and it was recommended to me that I need Suboxone. So I'm just trading one addiction for another, and the doctor's not even going to be, if you have a doctor that works towards incentives, here we go again. We're just igniting what's going to be another epidemic.
So why are they doing that? What is the purpose of reducing those restrictions? Why is it to look for a quick fix, to try and get as many people on
the article says, what are the pros of the new prescribing guidelines? A positive is the increased access for providers who previously were not prescribing because of the training obstacle. Now for up to 30 patients with OUD, providers are not required to take additional education. It is an important note is, however, there is not a federally imposed education requirement in order to prescribe any other medications. And the original legislation had a discriminatory impact on people who have substance use disorders. So, I mean, it's a really sad thing. Like I challenge doctors, if you take a code of on an oath, right? To do your best and to help somebody. And if you're not educated on the dangers of Suboxone,
that makes no sense to me. This makes no sense to me because they do CEs, certificate of education from these pharma companies where they'll lock them in a room, or they'll go into a room and they'll sit and learn about the drug. They'll do it at whether it's a casino or some kind of outing, and they all go in a room and they sit and they hear about the product, and then they go off and do whatever it is they do. Because there's usually a fun component into or food or whatever, but it just doesn't make any sense that why wouldn't a company, what is the parent company that's making this, or are there a bunch of them?
Oh, there's a lot of different people that are providing this now, I believe. I have no idea. I mean, it could just be Purdue. I have no idea.
So
I
why
have no idea.
wouldn't they do that? Like, what's the reason why they're not educating these doctors, and why? I don't understand why this current administration would loosen those restrictions. Like,
So I think what they're trying to do is give people more access to something that will help curb the opioid addiction problem, right? That's the goal. Like that's the real goal. It's like, okay, if we give people, more addicts, more people that suffer from addiction, the access to a tool, not the solution, a tool, maybe the overdoses and everything will go down. I don't know.
right,
I
right,
think that's their big goal. But see, so Peter Coleman from Coleman Institute did a 3-year study, and I sat in one of his classes a couple of years ago at a mental health symposium, and he did a 3-year study. And his three-year study was people on Suboxone with no supportive services, no accountability, no blah blah blah. People on Suboxone, supportive services, accountability, check-ins, etc. And then people who think they're on Suboxone, again, no supportive services. People not on Suboxone, again, with all kinds of tools and supportive services, right? And it was a 3-year study. And what he discovered is the highest success was the people on Suboxone with all the supportive services with a plan. So the plan was, you're on Suboxone for about a year, and then you taper down off of it, because you can't just go off of it, because you'll go into pretty severe withdrawals.
right.
You taper down, and then you go on Vivitrol, which is another, but it's not a synthetic. You go on Vivitrol for like a year, 2 years, depending upon your cravings, depending upon who you are. But all those supportive services, the check-ins, the accountability, the therapy, along with the Suboxone, they had a really good success rate for people staying in long-term recovery.
That was my point in the earlier conversation, is that where's the plan, right? You can't, if you don't have a plan, how are you going to like move forward? And whether it's the 13 to 17-year-old going to rehab and then comes out, what's the plan to do that? So the fact
don't
that
have a plan, I mean, I'm sure that there are good intentions. I'm sure that when somebody walks out of a treatment program, the phone calls have been made to the families to say, hey, your loved one did great, 30 days sober. It's recommended that you do A, B, and C. But we know what happens. They go home and they're great for a week or two, and then old behaviors start to slip back in. And before you know it, you're back, making the phone calls, trying to get back into treatment, because there's no long term. And that, again, goes back to what AWARE does, right? AWARE is the only program in the country that is 52 weeks long. It's called IHAT, in-home addiction treatment. It has its own billing code, and, sustainability for it is good. They don't put a measurement on it. Like, they'll tell you how many people we have that have graduated, but we're not putting a measurement on it because you just can't measure. Like, you can't measure recovery. You can't say, okay, if you have, 50 years of recovery here, you stand here, 40 years here, you can't do that.
Well, you could still be a horrible person and be in recovery, right? So that's the other thing. It's not like just because you're in recovery, everything is hunky dory.
Right.
Right.
It's Suboxone is a tool, and that's the thing. It's a tool. And if you're prescribed Suboxone, if you're prescribed Sublocade, if you're prescribed Vivitrol, if you're prescribed Antabuse, any of those, they're tools. They're not.
Are there any materials? Are there materials that they hand out when it's prescribed, or they're just like, here, go take it?
I have no idea. I know that, like my son was on it. He was forced to be on it because he was chronically overdosing, and they DCF threatened to take his child away. And this was years ago. And so they told him he had to go, DCF told him he had to go on it, different state. And he hated it because he had had sustained recovery the old fashioned traditional way with abstinence. And he knew what to do. And it was like, it went against, and he really struggled with it. It mentally made him not feel good. It mentally really beat him up. And, and detoxing from it was not fun. But I don't know if he got, I know like when he went to get his prescriptions, the doctor offered him other drugs, offered him benzos and other drugs, like that's just what's going on. You go to a Suboxone clinic and there's a line out the door waiting for people waiting to get their prescriptions. Sometimes they do urine tests, sometimes they don't. It really, and this is what this is going to do. Doctors are just gonna, it's, I think it's just opening up a really bad can of
Big
worms.
can of worms. Yeah, it's very, very interesting because I'm looking at it like, you know, it's such a crisis that people, the government doesn't really know what to do. So this is like throwing spaghetti against the wall, hoping that that is the thing that will fix the problem because nobody has an answer.
No,
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 So okay, what was the other thing that you wanted to talk about? That other article from LinkedIn.
this is it. This
Oh,
is the
that's it.
one.
Okay.
Yeah,
Oh,
this is it.
okay. So
Yeah,
now are
yeah.
these is Buput uh
Suboxone.
Suboxone prescribed? Like what's the average age of it being subscribed? Like how old are people that usually get it?
I've got 17-year-old kids that have been prescribed it. I would be, I don't know. I don't think there's a limit, which is
Okay.
insane. So, you talked about people going into like treatment, right?
Right.
You got people going into treatment, whatever the age is, and they go in as somebody who used alcohol and say cocaine, and they go into these treatment centers and they are put in with hardcore heroin addicts, street hardcore heroin addicts. And more times than not, these people come out and they're like, well, I really got educated on, other drugs. And if there's no follow up, if there's no accountability, their addiction is only going to escalate. So I'd be curious to take a poll someday of when you went into treatment, what was your drug of choice? When you left treatment, what was your drug of
That's
choice?
amazing. So speaking of other drugs, I know we talked recently about methadone or not methadone, methamphetamine has kind of made a comeback. Like, what do you do to withdraw from a methamphetamine? How does that happen? Is it
So
the same
meth,
thing?
there's no treatment for meth. Supposedly, there's no withdrawal. So what meth does is it keeps you awake, right? It strings you out. And then what happens? What happens when you don't get enough sleep? What happens if you were awake for like 3 or 4 days in a row? What happens?
I don't know. I'm only awake for like a night, but usually,
but like, but mentally, you start to deteriorate, right?
sure.
You start to have. So now you put like a drug that makes you paranoid, and you're not sleeping because the drug's keeping your brain stimulated, 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 stimulated. You're not sleeping, you're not eating. And, so what happens is when somebody stops using meth, they just basically sleep for 2 or 3 days.
I can see that. I could see
Yeah.
that. I mean, Adderall kind of has the same effect too.
Yeah. It's a stimulant. Yep.
In a way, where so no, this is very interesting because it's like, it sounds like heroin has or opioids have an antidote to it, but methamphetamine does not, nor does cocaine, right?
Yeah. There's nothing for cocaine. There's no tool for cocaine. It's just abstinence.
Okay.
They're starting to treatment centers are starting to recognize, but we still run into in order for insurance, like it goes back to the old insurance thing too, right? In order to qualify for insurance, you can't go into a treatment center for a cocaine problem. You have to
Really?
have,
Why? Why?
because it's insurance won't pay. They don't feel it's an addictive substance, which is insane.
What?
So yeah, you can't like
Since when?
you have to so you have to have like something else. So I'm not saying that this is what we used to do, but it was always suggested to say I have an alcohol and a cocaine problem. And so then you would go in for the alcohol problem, but you would be addressing the cocaine problem too. So they're typically like together, the alcohol with the cocaine. Yeah, it's really messy.
It
It's
sounds
really,
kind
really
of
messy.
it sounds a little corrupt, to tell you the truth, in a lot of
Right. And
ways.
meth, like if somebody says I'm a meth addict, you can't just go in for meth. You have to have something else to go with it. I don't know. It'd be an interesting. I'd have to do a little bit of research on it, but it would be interesting to dissect that as to why. You know, treatment centers will say cocaine on them, and they'll say meth on them, but when you go through like the whole admissions thing, you have to have that like other substance with
Isn't
it.
it amazing? It's crazy. Uh, well, no, thank you for bringing this up. This is a great topic. I think I find it very interesting that they're doing this. I'm not really sure, unless they think it's just a scattershot approach to try to, just kind of throw something against the wall, like I was saying, to try to help the problem. What doesn't sound like it's the smartest move to not provide education for
No,
folks, for
I mean, I
doctors.
think the best thing that we can do is, support the idea, but have something in a plan in place, right? Like that's just it. Like a good, it'd be interesting. We should probably get like either Jess or somebody from Coleman, Column from Column Health. So Column Health is in Massachusetts, and they are a Suboxone,
Okay.
Vivitrol. I don't know if they provide Sublocade or not. Um, but they are a clinic. And what I love about Column Health is that you go in and they do all the medical stuff, and you're assigned either a social worker or a therapist. You have to participate in their office, and at least, I don't know now because of COVID, but at least once a week you have to come in for like a meeting,
Right.
a group meeting, a support group meeting, and you have to have a plan. So okay, what's your plan? What's your long-term goal? Well, I would like to get off of Suboxone. Okay, what are we looking at? How is it going to go? And they don't just say here's 16, here's 16 milligrams. We'll see you in 4 or 5 days. It's okay. You have to work up to it. It's kind of like what good methadone clinics do, right? Methadone clinics will not give you a week's worth of methadone. Like you have to get to a point of going to every single appointment. So every single day you have to show up at that methadone clinic. You have to give clean urines consistently. You have to meet like a good methadone clinic will have weekly or biweekly check-in with a therapist. It might only be 15 minutes, but it's still a check-in. And then after X amount of months, they'll give you maybe 2 days worth of take homes. So you could you could actually sleep in and you wouldn't have to go, get up at whatever, because methadone clinics are typically 5 a.m. to like 1 p.m. That's when they're open. So you have those lines outside the door, people lining up to get their methadone. I mean, that's kind of like what Column Health does with the whole Suboxone thing. You earn it. And you have to bring your foils back, and you get tested to make sure that your levels are where they're supposed to be.
Wow.
I mean, I think if they're going to do this, then there should be some regulations in place, some accountability regulations. I don't think that it should just be like, okay, here's your Suboxone script. See you later. Bye. I'll see you in a month. I think that I think they should put more accountability if they're going to allow doctors to do that.
On both sides. The doctors
Yeah.
need to have accountability too. Like
Yeah.
both of them, both patient and doctor should have accountability, kind of working in collaboration together
Right.
from a patient
Right.
doctor. All right. Well, thank you. Thank you for the Chris's take. And
That's so random.
I know, well, because I knew you had some things on your mind that you wanted to get out there. So
This article is very upsetting. It makes me sad that it's a very loosey goosey. I'm hoping that there's just stuff we're not seeing that isn't printed in the article. You know, behind the scenes stuff that will be there for them.
yeah, it just doesn't sound like it's like they're lacking information in order to make that decision. Like they're not hearing the data,
Right.
or they're
Right.
not understanding the data and I know there's a ton of studies that are done on it too, like volunteer studies
Yep.
that they
Yeah.
do. Some of the hospitals are doing it. So, are they ignoring the research? I don't know, but
I don't know. We only
I,
get the stuff that grabs their attention. I mean, that's the problem with media, right? They don't give you they give you just enough of a feel good story to get your attention, but everything else is drama. It's drama and
exactly,
it's
it's got to be
controversial.
yeah, if it bleeds it leads. It's kind
Yeah.
of so
It gives you the opportunity for us, like for what we did. We could be totally wrong on this, but we're basing what we know on this article, right? And we could be totally wrong. There could be all kinds of regulations in place that they just haven't. So they've only removed the educational component. You know,
right.
maybe
They're
there are.
glossing, so that's irresponsible journalism at the same time, because if
Right.
there's more stories to it, then we're relying on the news to give us the the media outlets to give us the information, and if it's not fully um it's not the full picture, then that's irresponsible too. So we're gonna have to look that up and see
Yeah.
what's out there.
Maybe we could.
I'd
Maybe we
like
could
a
reach out.
report by next week. I'd like a report from you next week.
Maybe we could get. Maybe we could get. Maybe we could get the woman. Wait a minute. I'm trying to pull this article up so I could see her name from BMC. Is it BMC or is it? Yeah, it's BMC, right?
It's BMC, yeah.
Why don't you use your great skills and we'll try to see if she come on a show and talk to us about this.
I got someone we could talk to. All right. That sounds good. All right. Well, that's it. That's our show for the week. Thank you, Kris Long.
Yes, sir.
Thank you, Mike Weber, back at Mission Control in Foxboro. We're hoping to be back in studio at some point in the near future, and we can see each other. And haven't been in the studio for a long time, so it'll be good to get back there.
Forever.
And that's our show. Hopefully, Willie will be back next week after his assignment is complete. And that's our show. And please like us at The Map 2020 on Facebook. And we'll see you next time.
Great weekend.